exam film. Jejunize, I'll show you. So the mucosal fold the order reverses. And because the jejunum gets destroyed, the mucosal fold. So ileum is trying to help. And there is regeneration of mucosal folds. And in radiology, this is how you diagnose it, right? So, so that's a very popular exam film, jejunization of ileum. So this is mucosal fold. Now, look at this. And here you can make out. This is a barium meal follow through. And you can see the mucosal folds of the jejunum. And you can see the ileum. And you can agree, all of you agree. Do you agree? Smoother, isn't it? Less. So this should be, and if I reverse this order, simple as that, celiac disease. Simple as that. So this is the mucosal folds. On a plain abdomen, if you ask yourself, where is this gas? This is that bubbly type of appearance, and then it is peripheral. So this is the cecum and the ascending colon. This is feces. Please remember, feces happens in the large bowel. It has got bubbly appearance. And look at this. You know, do you see these folds? Do you see these folds here? So this is portion of the jejunum, actually, portion of the small bowel. You can see this you can see in rectum and the sigmoid. So there is so many variable type of appearances. Quick recap about the parts of large bowel. Ileocecal junction. Mr. Appendix is sitting here. This is cecum, ascending colon, hepatic flexure, transverse colon, splenic flexure, descending colon, sigmoid colon, and then the rectum, and of course the anal canal. These points, hepatic flexure and splenic flexures, are fixed, right? So the transverse colon, I have already told you, it can be variable. It can be a necklace. It can go into the pelvis. So beware of that. So here is a barium enema examination, which tells you the same thing. So we have got a Foley's here, and we have put in barium, and we put in some air inside to distend it. And you can see the sigmoid colon. This is the rectum, the sigmoid, the ascending colon, the splenic flexure, the transverse colon, the hepatic flexure, ascending, and the cecum. So this is the transverse colon. It all depends on what kind of patient is scanned, and at times you have got air like this in a normal X-ray, air like this. You can see the hostra. You can see the outline. Develop your eyes on the outline of the hostra. This is crisp and sharp outline. And in an exam case, which you will get, is toxic megacolon. Favorite exam case, toxic megacolon. You will lose the outline of the hostra. Rectum, this is the rectum, this is the anal canal. Rectum is MRI world. And I'll teach you a bit of MRI. The surgeons all of them want more MR. It's not your territory as gastroenterologist because they stage CA, rectum. But I'll give you a bit of brief when we come there. Not in this, in the colon session. So this is the rectum here. This is a female, and this one was a male. And then is the anal canal. So this is on a barium. We do a lateral film, and this is the rectum. This is the sacrum. So it is visible like this. Now this is the rectum, and then this is the anal canal. So if you see here in this film, you can see the large bowel all full of air, and then this is the rectum and the anal canal. Muscles outline in the retroperitoneum can be seen. I will not go into details, but there is a muscle which is this psoas. Psoas has got fat surrounding it. On each and every X-ray, you can see it. You see, this is psoas, and you can see it because there is fat. The interface between the fat and the muscle. Lucency, you will see psoas outline. I don't think so as a gastroenterologist you should be bothered about it, but just wanted to show you that this is the the both kidneys. You can see the outline of the kidneys. Here you are. You see, this is the Swas outline. This is the Swas outline. This is the kidney outline. And you can see it. Why? Because there is surrounding fat. Actually, if you stretch your imagination, you can see the right kidney also. But it all depends if there is feces in the gut anterior to that. At times you will not see it. If eagle eye people among you, potential radiologists, you want to change your specialty, has anybody picked up a bladder here? Can you see the bladder? Yes. So, madam, consider radiology. Okay. So, if you see here, uh, this bladder is slightly full of urine, and that is why, and you can see this outline. Don't go home with this idea that every bladder will be visible, but it can be visible. Now, this is the learning points in this session. Uh, as a clinician, you should know if there is obstruction or not. When three questions you need to answer, and as radiologists, this is what we have to answer for you. Is there obstruction or not? Question number one. What is the level of the obstruction? Is it small bowel? Is it large bowel? What is the cause of the obstruction? Etiology. Of course, CT is much better. But please remember, plain X-ray has got a role, particularly as a screening test. There is one entity where on a plain X-ray, Viva question once again, where on a plain X-ray, you will make a diagnosis and there is no role of CT. Yes. Say again. Here you are, sigmoid volvulus. Sigmoid volvulus can be and should be diagnosed on a plain film. Again, favorite in the exam, and there is no role of send it to Mr. Surgeon, and they will put in a flatus tube. Usually, they are decomposed. And these patients will come to you again and again. 3 months down the road, they will come again. So no need of CT, just do a plain film. So now, abdominal X-ray is not very good, 50 to 66% sensitivity, right? But still, it is as a screening test. And if your clinical goes slightly to the right side, you just do a CT scan when you are in A&E. Now, this is a take-home point. Please remember, take a picture of this. What are the difference between small and large bowel? Location. Now, small bowel location is central. Large bowel is peripheral. We call it a picture frame type of appearance. Fecal content will be absent. Fecal content will be present, that bubbly appearance. Vulvally conventis are present, particularly in the jejunum. They are absent. Hostra are absent in small bowel and present in. So these are the parameters on which you make your mind. Please take a picture of this one also. These are measurements to remember. Measurements to remember. And radiologically speaking, so I always use this word that on radiological criteria, because our criteria doesn't mean it's a black and white world, right? That on radiological criteria, if it is more than 3.5, I will say on an MRE that there is signs of obstruction. And you will be, we all also teach that treat the patient, not the X-ray, right? So you will always see overlaps. So this 3.5 doesn't mean that you open up the case, if you're a surgeon. You have to, think at it clinically. In ileal, more than 2.5%. Colon risk of perforation. Now, I always challenge this. In literature, if you open radiology literature, they will tell you 5.5 transverse colon, some say 6. Start measuring it today, and every case will be more than 5. But I'm teaching you what is in that, references, right? But don't go home with this idea. Don't get excited if you see more than that. One thing on which I really get excited is this thing, cecal diameter. And I actually dial the surgeons. Wow. I use the word, signs of impending perforation. If I see a cecum of 9 centimeter, or some say 10, I'll call them, this is large bowel obstruction and this is it. Consider it, impending perforation. Pseudo obstruction is where you will lose your, all kind of confidence, because pseudo obstruction is something which you see in UK so often. Patients come in A and E. They are usually bent bowed patients. They will come from nursing homes, etc. And believe me, 22 centimeter bowel, chronic. It is chronically distended. It is full of feces. And what to do? And I'll come back and teach you something else about it. So this was uh, want to know your abnormal. First of all, you know what is normal, right? So this is a normal X-ray. This is transverse colon, stomach, small bowel. If you see carefully here, you can see a bit of valvulae conjunctives. So now let's exam tip. This is for radiologist, right? But so don't overload yourself with this exam tip. But as a radiologist, I teach my students that when you see a gas in an abdominal X-ray, you have to, first of all, consider where is this? Is it in the bowel lumen? Is it outside the bowel lumen? We show cases like, and for you also it is important, pneumobilia. In the biliary tree there is air, or portal vein. And is it in the wall of the hollow viscous? This is very important. I'll show you cases, but I will not teach you in this session. I don't want to overload you. But in our exams, we show them where on a plain X-ray, within the wall of the bowel, there is air. What does it mean? Ischemia, isn't it? So, which we see on a CT scan also. So these are the three things, but I will concentrate here. So I will be generous enough of not teaching you these two things. Gas in the bowel wall. So once again, whenever you see gas in the bowel wall, which segment of bowel contains the gas? Is the caliber is normal? What is the most distal point the gas has passed in the intestine? And when it is transverse colon, please look at the mucosa, look at the hostra. And this is, exam favorite, as I have told you. This is a take home. Take a picture of this. Uh, what are the signs of small bowel? What is the signs of large bowel? This is a repetition of what I told you, how to pick up which bowel segment it is, number one, and go into the diameters. Is it distended? Measure the diameter on your packs. And also look at what is the distal most portion the bowel is distended. Please remember, in complete obstruction, you will not see any gas in the rectum, but it will take about 24 hours to develop that. So in the first day, if the patient comes with complete obstruction, there might still be bowel. In our descriptions, we teach our radiologists, our trainees, you have to mention, is there gas in the rectum or not? If there is no gas, it's a black and white word, complete obstruction, right? But it takes time not to dwell. Now, if you see here, this is bowel loops. So first of all, the exercise which bowel loops, and you will agree that these are central, and they are going right and left, but many of them are central. You can see these valvulae conjunctives. So what is this? Small bowel obstruction. So this is small bowel obstruction. Now, the most common cause for small bowel obstruction are adhesions, but there are other. Please remember that 80% of adhesive small bowel resolve spontaneously. That is why surgeons love, they send it to us to give gastrographin, and at times it becomes therapeutic. The patient just treats himself or herself. This is slightly more tricky case of small bowel obstruction, because this thing initially looks like what we call transverse colon. But look at it carefully and you will see these valvulae conjunctives going all the way. Then you see here, and there are a few valvulae conjunctives. So this is a trickier case of small bowel obstruction. Please remember, that on a plain abdomen, you will only see a distended bowel loop if it has got gas. But in the real world, many have got full obstruction with full of fluid. And on a CT, you will pick it up, not here. That is why our sensitivity is only about 50 odd percent. This is a, yes, small bowel, large bowel. What is this? Large bowel. Complete or what? On radiological criteria. And why do you say complete? Perfect. So, madam, radiology. Yeah. So this is my second favorite topic, convert people to radiology. So, and I've been able to do quite a few over the years. So I'll be available in the break. So this is, if you see, there is a complete uh, cutoff at the sigmoid colon. You don't see anything more. And then you have to pick up that things proximal to that is dilated. This is large bowel obstruction. Yes, this is where you will be. What is happening? These patients will come to you in A&E. This is a nursing home patient. Interestingly, 92 years. And did you, radiologist among you, did you see something interesting? 92. Here you are. They left it there for, I think, 50 years. You see this thing? So this is the type of patient. What is what? Everything is distended. Everything is distended. And so please remember, when these patients come to you, clinical tip is look at the packs, look at the previous ones, because they will be coming to you since years, right? And with the same thing, distension and that thing. In push comes to shove, ask for a CT scan. We used to do a lot of bariums for these enemas and gastrographin. And the idea was, and initially it looks horrendous, but I have done myself quite a few, but maybe 15, 20 years ago. You can actually manage for the gastrographin to go all the way to the cecum, and then you get that. Now we don't teach that because we have got CT, right? And so in CT, then you can trace everything and look at these measurements. They are horrendous. Please remember a disclaimer. Though we call it pseudo obstruction and we take it casually, please remember it can cause perforations, right? It can cause, and I have seen cases, perforations, where, because there is so much distension that at one point there will be necrosis of the wall and the patient will perforate. So pseudo obstruction is something which you will see. You compare it with the previous one. If the patient is not tender, I think just leave it there. Nobody is stopping you to ask for a CT. But if there is clinically, ask for a surgical opinion. If you see, this is our book by the name of, this is the Bible of differential diagnosis for a radiology trainee. So I teach always the radiologist from this book, and you cannot pass your FRCR exam without this. There are 600-700 differential diagnoses. Radiology is the art of differential diagnosis, and we teach that this is the sign, what can it be? So if you see, this is megacolon in adult, colonic dilatation more than 6 centimeter. Do you see this? Non-toxic, without mural abnormalities, and toxic. These are the two headings. This is extremely important for you as gastroenterologist. Again and again, I'm telling you, this is known as toxic megacolon. Mural abnormalities, loss of hostra and fold, IBD, infectious, and then what can be the causes of this? Causes can be UC more common than Crohn's, infectious colitis, ischemic colitis. And these are the other cases of which, dilatation. So this is megacolon. Yes, spot diagnosis. Okay, somebody has said cecal volvulus. How many for cecal? Okay, a few. What else can it be? Sigmoid. How many for sigmoid? Okay, equal, by the way. The difference between a cecal volvulus and a sigmoid volvulus is big. You know what? Cecal volvulus always surgery, 100% surgery. You have to open the case. Sigmoid volvulus usually are treated, more conservatively. They just put in a flap, deflate it. And sigmoid volvulus can be chronic as well as acute. So I'm not saying that there will not be surgeries in sigmoid, but in cecum, always 100%, it has to be acute, right? The key finding is based on anatomy, Hostra, Hostra. Sigmoid is devoid of Hostra, right? Sigmoid, the Hostra become very less in. So the outline doesn't contain Hostra. Cecum will have Hostra. This is the exam scenario. Look at the outline. Do you see Hostra? No. So this is the take home point. Look at the shape. It will be an inverted U, right? So sigmoid is quite characteristic, but key point is inverted U appearance. There is no hostra. It is a smooth outline. Otherwise, large vowel has got hostra, right? Now, these are the two loops, and this gives a particular, this is one loop, and this is the descending loop. In between the walls, they produce this kind of appearance. We call it the coffee bean sign. It looks like a coffee bean, yeah? Stretch of imagination. But this is sigmoid volvulus. We teach sigmoid volvulus in more detail. I will not teach you because if you get it in your exam, you are going to get a classical case. But we show more, non-classical cases. So this is another one. Key point once again. Look at this wall. Look at the hostra. There is no hostra, smooth outline. Look at this one. It goes up. Look at this outline. Look at this outline. And you can again see a bit of, coffee bean sign. These are the opposing walls. These are the opposing walls. So this is sigmoid volvulus. Yes, now, cecal volvulus, right? And cecal, if you see here in cecal volvulus, the concept is that the anatomy is at fault. Basically, please remember the cecum has got, there is a mesentery there. So these people will have a inborn sort of a large mesentery, right? And that is why the cecum moves. And interestingly, it will move either to the, classical on the left side and left upper quadrant, just like this case. It moves there and then there is a twist with it, right? But key exam point, look at the hostra and you've got a differentiation. So anatomy wise, you say, what is happening? Cecum is, this is not the location of cecum. But if you know your pathology, this is what happens. So it will be always here or here. It will never be here. Interesting. It will never be there. So this is cecal volvulus. This is the CT scan of the same case. And on a coronal sequence, you can see how, this is the ascending colon. It has come here and this is the inverted type of appearance. Actually, this thing is the ileocecal junction. So this is the CT scan of the same case. Yes, exam favorite hint. What is this? Toxic megacolon. And why do you say that? Loss of hostra. Excellent. Diameter is more. Excellent. Let's take it further. Now, interestingly, on a plain film, we are using the word, can you imagine we are using the word mucosa and we do it. Plain film. In MSK radiology, radiologists are the only people in the world who use the word bone edema. A histopathologist cannot do it. So we see bone edema, right? On a plain abdomen X-ray, you say, are you? But we use that word. There is mucosal, edema. Why? If you see here, look at the crisp and sharp outline of the transverse colon. Look at the hostra. Remember these words, crisp and sharp outline of the hostra. Where is that crispiness and sharpness? Gone? Agreed? With that, Look at this thumb printing. We use the word thumbprints, thumbprints, thumbprints. So these are, this is the sign of mucosal edema. And then if you look carefully, because it is distended, you can see something projecting inside. These are pseudopolyps. Pseudopolyps. It is so horrendous that you can see tags of, if you do an endoscopy in these cases, in a colonoscopy, mucosa. So loss of hostra, thumb printing, pseudopolyps. Another two examples, again classical exam cases. Whenever you see a distended transverse colon, look at these features, look at the outline, and you will agree that it is not crisp and sharp. Stretch of imagination, and once you know it, you can see between, what we call thumbprints. Look at this one. Again, loss of hostra, you can see pseudopolyp, etc. So toxic megacolon, next comes the question, what are the causes of toxic megacolon? As a gastroenterologist, you must know UC is the most common. UC is the most common. Crohn's is number two, right? And then, of course, infectious colitis, ischemic colitis can also cause this. And infection, of course, there are many types of infections, viral, etc. So this was our beginning, the opening over. And so this was the protocol. I just a recap, but what we have learned in this session is that although the protocol is extensive, as a non-radiologist, you have to particularly concentrate on the lumen and particularly to rule out if there is obstruction or not. This is your role, right? As we use it as a screening test. And if you are worried, if you say that there is something, then you go for a CT scan. And what we learned in this was, features of small bowel obstruction, large bowel obstruction. I told you a few exam favorites, sigmoid volvulus, cecal volvulus, how to differentiate, and toxic megacolon, the favorite of favorites, right? So thank you very much. 5-minute break. This feedback is for online people only. Of course, there is a single feedback which you will give for the whole session. But what is projecting is for online. For face-to-face, you have been provided a feedback form, email. If there is any question, I am here. We will start the next session in 5 minutes. Thank you. Okay. Yeah, you are being sent the feedback form, but no need of filling it up right now. You can fill it up later on. One feedback for the whole course.
When do they need the laptops for the workshop?
So if anybody is interested to see cases workshop wise during the session, in the next session, I'll show you a few of them. So you just open it now. The esophagus normal, and there is another one, I think a barium, and there is a esophagus T4 tumor. These are the ones which I will go through in the next session. Yeah. No, no, sir. We just there was a lot of these are things which are going on here. At what time people bring on anything else to see. There is no, I think for me, obviously, but significant, clinical significance, right?
demos by the sponsors. Not now,
In the next.
during the coffee breaks and lunch breaks.
You want to announce or
Excuse me, everyone. So we got sponsors out, not now, during the coffee break and lunch breaks. Please feel free to talk to them. Only then they will come again for the next meeting. And on top of it, we're going to have some demos on the zinc taken tubes and few more, therapeutic procedures just to pop in and just get hands-on. Yeah, I know you will not come across, but most of the GI trainees possibly will be benefited from that. Yeah, thank you so much.
We have put generous breaks, 30-minute coffee break, 60-minute lunch break. So you've got a lot of time. Please do as well as. Coffee break is after if somebody can give them a shout, we are starting in 200. We don't have time because the tea break is coming. Just give them a shout that we are starting. Yeah.